This is the 9th in a series of videos on glaucoma training. Module 9, Assessing the Optic Disc. The learning objectives in this module are to understand the changes that occur at the optic disc in glaucoma, to know how to examine the optic disc, and to know how to record the appearance of the optic disc. Glaucoma is a condition characterized by optic disc damage. Detection of glaucoma and its progression is based on the identification of abnormalities or changes to the optic disc or retinal nerve fiber layer, RNFL. Knowing how to compare the normal optic disc and the glaucomatous optic disc is crucial for developing your ability to recognize the changes that occur. NICE NG81 recommends optic nerve assessment and fundus examination using a stereoscopic slit lamp biomicroscope as a formal part of the diagnosis of glaucoma. Optic disc assessment can be challenging, but there are clear procedures and good practice to draw on in order to carry out an informed assessment. The normal optic disc. Evaluation of the optic nerve and retinal nerve fiber layer is essential in recognizing glaucomatous damage to the eye. The optic nerve head, or optic disc, describes the area of the optic nerve that is visible on clinical examination. The optic disc is the point where the axons of retinal ganglion cells come together, pass through the lamina cribrosa, and are bundled together through the optic nerve towards the brain. It is also the entry point for the major blood vessels that supply the retina. Visually, the optic disc is vertically oval, although there can be significant variation in the size and shape. It contains a central cup, which looks paler than the surrounding tissue. Here is a picture of a normal optic disc. It's a 35-year-old healthy patient. The optic disc appears pink with sharp margins and a cup-to-disc ratio of approximately 0.35. The vasculature is normal in course and caliber. The striated sheen radiating outward from the disc is evidence of a healthy retinal nerve fiber layer. In the normal optic disc, there's the scleral ring, or Elschnig's ring, and it represents the edge of the optic nerve head and appears as a pale white circular halo around the edge of the disc. As the nerve fibers approach the edge of the disc, they bend over the scleral ring, which marks the edge of the disc, and then down its inner surface. Note that the visibility of the scleral ring is greater in the temporal sector. It decreases in the superior and inferior regions and is hardly visible in the nasal sector. Loss of nerve fiber layer in glaucoma can make the scleral ring more visible due to loss of overlying tissue. The scleral ring itself does not belong to the optic disc. This is important for all optic disc measurements because the inclusion of the scleral ring as part of the optic disc falsely enlarges the neuroretinal rim and decreases the cup-to-disc ratio. The neuroretinal rim is the dense packing of nerve fibers just inside the scleral ring. Neuroretinal rim tissue is pink or orange in color and is a good sign of vascular perfusion. The optic cup is the central area of the optic nerve head inside the neuroretinal rim. It has a pale yellow-white color. The cup edge, where it meets the neuroretinal rim, is best seen by the bend in small and medium-sized blood vessels as they descend into the cup. The optic cup is generally fairly round or horizontally oval in healthy eyes. The retinal nerve fibers are spread unevenly across the surface of the retina in a thin layer which has a feathery appearance, best seen immediately above and below the optic disc. In a healthy eye, bright striations are visible, and the retina glistens in the regions in which the RNFL is thickest, superior temporal and inferior temporal from the disc. Optic disc and cup size. There are roughly 1.2 million nerve fibers passing through the neuroretinal rim of each optic nerve head. The number of optic fibers and the area of the neural rim they comprise is constant regardless of overall disc size, and therefore generally there will appear to be more cupping in a large disc and less in a smaller disc. The average optic disc has a vertical disc diameter of approximately 1.88 millimeters and a horizontal disc diameter of approximately 1.77 millimeters. The European Glaucoma Society guidelines suggest the following classification for disc size. Small discs would be less than 1.45 millimeters. A medium disc is between 1.45 and 1.9, and a large disc is greater than 1.9 millimeters. The optic disc diameter, although largely independent of refractive errors in low to moderate refractive errors, say -5 up to +5, is generally larger in myopes, those greater than -8, and smaller in hyperopes, greater than +5. Optic disc size and physiological cup size are genetically determined. Ethnicity can be a factor, with people of Afro-Caribbean heritage having on average larger optic discs. The size of the cup may also increase slightly with age. The photograph of the flowers in a vase is to demonstrate the different appearance of cup to disc ratio dependent on how large or small the overall optic disc is. So 1.2 million nerve fibers passing through a small scleral opening will give a small cup, as the picture on the left depicts. And 1.2 million nerve fibers, in other words, the same amount, passing through a large scleral opening would give a large cup, as in the photograph on the right. Note that there are still 1.2 million nerve fibers passing through both, and therefore this would be a normal situation, and that the situation on the right-hand side, just because there's a larger cup to disc ratio, would not suggest that there was a problem. It's just a larger disc. The detection of glaucoma and its progression is based on the identification of abnormalities or changes in the optic disc or the retinal nerve fiber layer. The spectrum of disc damage ranges from highly localized tissue loss with notching of the neuroretinal rim, right up to a clear enlargement of the cup. Changes can be detected during a close evaluation of the optic disc. The isn't rule is an easy way to remember how the optic nerve head is supposed to look in most normal eyes. The inferior rim is usually thicker than the superior rim, which is thicker than the nasal rim, which in turn is thicker than the temporal rim. In a glaucomatous eye, you begin to see vertical thinning with atrophy along the inferior and superior rims. When optic nerves don't follow the isn't rule, they may have sustained glaucomatous damage. Note, however, that the isn't rule may not hold in many healthy eyes. This is a depiction of the isn't rule. The disc shown on the left is regarded as normal, where the inferior neuroretinal rim is thicker than the superior, which is thicker than the nasal, and then the temporal. In the picture on the right, the inferior rim is not thickest, and in this situation, this would be regarded as abnormal, as there would have been loss to the neuroretinal rim, both inferiorly and indeed superiorly in this diagram. So enlargement of the optic cup. Loss of neuroretinal rim tissue is an established feature of glaucoma. It can be circumferential or localized. The loss of tissue causes a loss of connection to the brain, which then causes visual field loss. Vertical elongation of the optic cup can be a common feature of the glaucomatous disc, as loss of axons tends to occur more in the superior and inferior regions. So vertical elongation is suspicious. Other suspicious factors include a cup to disc ratio of greater than 0.5, depending on disc size, meaning that a larger disc you would allow for a larger cup to disc ratio before considering it suspicious. Also inter-eye asymmetry of cupping greater than 0.2, and changes of greater than 0.15 in the cup to disc ratio compared to the previous visit of that patient. Assessment of the optic disc size is important to the detection and diagnostic evaluation for glaucoma. The cup to disc ratio indicates the vertical diameter of the cup as a fraction of the vertical diameter of the overall optic disc. The cup disc ratio is still commonly used in community and hospital practice as a way of describing the optic disc appearance. It is quick and easily recognizable to healthcare professionals. The degree of optic disc cupping is related to the size of the optic disc in normal eyes. A normal, large disc will have a relatively larger cup, and thus a larger cup to disc ratio than a normal, smaller disc. A normal small disc will have a relatively smaller cup than a normal larger disc. The key features to look for in glaucoma are enlargement of the optic cup and a companion loss of neuroretinal rim tissue as the patient ages. However, measuring CD ratio alone is insufficient in glaucoma, as a big optic cup in a big optic disc can sometimes be mistaken as glaucomatous, and a small or moderate cup in a very small glaucomatous optic disc can be assumed normal. This is why measuring optic disc size is an essential part of glaucoma assessment. The CD ratio versus disc diameter chart is a useful guide to indicate whether the CD ratio is a risk factor and takes into account both the size of the disc and the cup. For example, a CD ratio 0.5 in a relatively small optic disc of 1.2 to 1.3 millimeters may be abnormal. Conversely, a CD ratio 0.7 in an eye with an optic disc height of 2.3 millimeters would maybe not raise concern, as there is a matching between the amount of cupping and the height of the optic disc. The diagram on this slide shows the relationship between the disc diameter and the vertical cup to disc ratio. It also suggests a 95% confidence line on the limits of normality, with those discs that are in the bottom right section being less suspicious and those in the upper left being more suspicious based on the disc diameter and the cup to disc ratio. We also have a disc damage likelihood scale, DDLS. Cup to disc ratio on its own does not take into account disc size or neuroretinal rim changes and is subject to significant intra and inter observer variability. Focusing on the width of the central cup in just the vertical axis can also lead to the risk of overlooking thinning of the rim elsewhere. The Spieth Disc Damage Likelihood Scale is a grading scale to facilitate the diagnosis and management of glaucoma and relies on the optic disc as a direct indicator of the disease. It incorporates the effect of disc size and neuroretinal rim width into a clinical grading scale. It is highly reproducible and correlates closely with visual field loss. On this slide, you will see a diagram of the disc damage likelihood scale. It would be worth your while to pause the video and take some time to understand this, as it is a very fair reflection of visual field loss in glaucoma. The disc damage likelihood scale categorizes disc size into small, less than 1.5 millimeters, medium, between 1.5 and 2, and large, greater than 2 millimeters. This ensures that the disc size is measured to reduce misclassification bias based on disc size. The DDLS stage is determined using the rim to disc ratio for the thinnest part of the rim. DDSL stage 4 or greater can be a significant finding alongside additional indicators of glaucoma, such as optic disc nerve fiber layer hemorrhage and cup to disc ratio asymmetry, when assessing the need for referral to an ophthalmologist. Increased pallor. Following the thinning of the neuroretinal rim, a pallor associated with glaucomatous changes becomes apparent. The disc normally has a pinkish hue with a central yellow depression. A pale yellow colour, evident across a much larger area of the optic disc, can sometimes be confused with a large cup, but is, in fact, a result of rim loss. You can differentiate an area of cupping from an area of pallor with a stereoscopic image or view, or by observing a kinking of blood vessels at the cup margin. Vascular changes. Disc hemorrhage is an important warning sign of glaucomatous optic nerve damage. Hemorrhages associated with glaucoma are often observed in the inferotemporal sector of the optic disc. However, a disc hemorrhage alone isn't pathognomonic of glaucoma, as it can be caused by other factors. Circumlinear bearing. Bearing of the circumlinear vessel occurs when areas of pallor develop between the small branches of the central retinal vessels and the cup margin. Flyover or overpass vessels. These may be seen when rim tissue underlying the retinal vessels that cross the disc margin is lost. This can give the appearance of vessels floating above areas of deeper cupping. Bayoneting. In areas where the rim has been lost, retinal vessels can sharply change direction as they pass under the overhanging edge of the cup. Nasalization. Nasalization of the central retinal artery and central retinal vein is often seen as the cup enlarges. Peripapillary atrophy. Evaluation of the peripapillary area of the optic disc may reveal areas of atrophy. This atrophy surrounding the disc can be divided into an inner crescent, or beta zone, and an outer crescent, or alpha zone. The alpha zone is present in most normal eyes, as well as in eyes with glaucoma, and is characterized by a region of irregular hypopigmentation and hyperpigmentation of the retinal pigment epithelium. The inner beta zone represents loss of retinal pigment epithelium and correlates with visual field loss. It is seen with greater frequency and is more extensive in eyes with glaucoma than in unaffected eyes. Beta zone peripapillary atrophy is seen within the peripheral tissues of the optic nerve head and represents a loss of choriocapillaris and retinal pigment epithelium, leaving only large choroidal vessels and sclera, resulting in a characteristic white appearance adjacent to the disc margin. Other changes you may observe include focal notching of the neuroretinal rim, which leads to localized loss of the retinal nerve fiber layer. Changes to the retinal nerve fiber layer. Glaucomatous damage specifically affects retinal ganglion cells and their axons and leads to progressive thinning of the retinal nerve fiber layer. The cup can become larger in comparison to the size of the disc as a result of a localized loss of the RNFL. This loss can manifest as slit or wedge-shaped defect, but can also be diffuse and therefore easier to miss. Examination of the nerve fiber layer can be difficult and is best performed with red-free, that is green, light to enhance the contrast. So a quick knowledge check at this stage. Which of the following occurs in areas where the rim has been lost and retinal vessels have changed direction as they pass under the overhanging edge of the cup? Does this describe increased pallor, neuroretinal rim loss, optic disc hemorrhages, or bayoneting? The correct answer is bayoneting. A retraction of the retinal pigment epithelium from the disc margin, exposing the large choroidal vessels and the sclera, is described as increased pallor, peripapillary atrophy, optic disc hemorrhages, or bayoneting. Well, the correct answer is peripapillary atrophy. And this occurs when areas of pallor develop between the small branches of the central retinal vessels and the cup margin. What is it that we are describing? Inferior rim loss, neuroretinal rim loss, circumlinear bearing, or bayoneting? And this one is circumlinear bearing. NICE NG81, for use by optometrists in the UK, recommends an optic disc and fundus assessment with pupil dilation if necessary, using a stereoscopic slit lamp biomicroscope and an OCT or optic nerve head image if available, and to refer people with suspected optic nerve damage for a definitive diagnosis after also considering repeat intraocular pressure measurements. Measuring the optic disc. The most effective way to examine the optic disc is with a slit lamp and a high magnification binocular indirect ophthalmoscope lens. This will give a stereoscopic inverted image. Ideally, the pupil should be dilated. The main disadvantage of using direct ophthalmoscopy to view the optic disc is lack of stereopsis. The key objectives of the examination are to measure the height of the optic disc, the cup-to-disc ratio, and to examine the neuroretinal rim. With the slit beam coaxial to the observation system, focus the slit beam over the center of the optic disc. The beam can be narrowed, illumination increased, and the light beam adjusted vertically until it falls to the white margin of Elschnig's ring. The value can be read off the graticule on the slit lamp in millimeters. The orientation of the beam can be rotated to adjust for tilted optic discs or to measure horizontal disc size. Multiply vertical and horizontal values by the BIO lens magnification factor to calculate the actual disc height and width. Binocular indirect ophthalmoscopy lenses, also referred to as Volk lenses or condensing lenses, come in different magnification factors which must be taken into account when recording optic disc measurements during the examination. If you use a +66D BIO lens, then the height of the slit lamp beam corresponds exactly to the height of the disc, as it has a ×1 magnification factor. The +90D lens provides a wide field with less magnification, whereas the +60D lens has a narrower field but greater depth perception, which makes it a good choice for the optic disc examination. Common magnification factors of BIO lenses are the superfield lens is ×1.5, +90 ×1.4, a +78D is ×1.1, the +66D is normal at ×1, and the +60 at ×1.15. So what to measure and check? Measure the vertical disc and the vertical cup size and correct it for your BIO lens that you've been using. Next, measure the width of the thinnest part of the rim and categorize the disc size as small, less than 1.5 millimeters, medium 1.5 to 2, or large, greater than 2 millimeters. Calculate your CD ratio and your rim to disc ratio. If no rim is present at the thinnest part, rim to disc ratio is 0. If the rim is as thick as possible, that is no cup, the rim to disc ratio is 0.5. Measure the extent of the rim absences in degrees and assign a DDLS grading stage. What to check? Is the vertical cup to disc ratio greater than 0.5? Is the cup to disc ratio consistent with disc size? Is the cup more vertically oval than the disc? Does the rim configuration differ from isn't? Are there any notches or pallor regions in the neuroretinal rim? Are there any disc hemorrhages? Is the inter-eye cup to disc asymmetry greater than 0.2? Or has there been a greater than 0.15 change in the cup to disc ratio since this patient last has been examined? Documenting your findings. Optic disc. Document your findings clearly, making a careful, detailed drawing of the optic disc to replicate key details to refer back to when monitoring in the future. Record the type of BIO lens used when making the measurement. Remember that all indirect BIO lenses provide an inverted image of the object being viewed, so you might find it useful to turn the piece of paper upside down before drawing. The image will then be normalized when you turn the paper the right way round again. So a sketch drawing. You should document the following structures: the size and the shape of the optic disc, the size and the shape of the cup, any neuroretinal rim thinning at the vertical cup, any disc hemorrhages, the position of blood vessels as they cross the rim and cup, scleral crescent, peripapillary atrophy, nerve fiber layer defects, tortuosity of blood vessels, and arteriolar narrowing. Here we have case study 1 on Janet Smith. Describe the right and left optic discs using phrases that help in comparison of the two eyes. Well, the right disc has inferior, superior, and temporal neuroretinal rim thinning, pale temporal neuroretinal rim, significant peripapillary atrophy, and nasalization of vessels. The left disc has inferior and temporal thinning, pale temporal and inferior neuroretinal rim, significant peripapillary atrophy, and nasalization of vessels. Consider the cup-to-disc ratio in each fundus image. Which measurements below do you think most accurately describe the cup-to-disc ratio for each eye? We will return briefly to show you the images again for you to make a decision. And these were your options once more. So the referring optometrist in this case noted a cup-to-disc ratio 0.8 for Janet's right eye and a cup-to-disc ratio of 0.85 for her left eye. Optical coherence tomography, or OCT, is a valuable tool in investigating and diagnosing early glaucoma. In an OCT measurement, cross-sectional images of the retina are produced by measuring echo delay and intensity of reflected infrared light from internal tissue structures. Optic disc assessment is a very challenging aspect of glaucoma diagnosis, and OCT imaging can provide an additional source of information relatively quickly to help aid diagnosis and monitor progression. However, it is not currently a reliable substitute for optic disc examination and clinical evaluation, and is not available in all settings. This is a diagram showing the type of result you get from an OCT exam. So in summary, careful evaluation of the optic disc is necessary for the diagnosis and monitoring of glaucoma. Measuring the optic disc size and calculating the cup-to-disc ratio are essential in helping you to identify glaucomatous damage and to monitor its progression. These need to be made in conjunction with careful observation of the disc appearance. An OCT scan, where available, can provide a useful aid to the detection of glaucoma, particularly in its early stages, but is not currently a reliable substitute for optic disc examination and clinical evaluation. Make sure that you have achieved the learning outcomes for this module, that you understand the changes that occur at the optic disc in glaucoma, that you know how to examine the optic disc, and you know how to record the appearance of the optic disc. Make sure to have any questions that you have answered.